Rob Shapiro from Technique Peak. So a lot of times we move the hip around and we kind of think they have really good hip flexion. And what happens is, which Justin doesn't, so it's going to be harder to show. But sometimes we go up and he moves pretty well. And let's say they get way up here and then, good hip flexion. We truly want to see what hip flexion is. For Justin, it feels like it's pretty early, but I want to be able to determine it. So I could use we call the thumb spit out test. Probably not a great word for it, but we're going to go ASIS. We're going to go just distal to it. We're going to see where the head of the femur, the area where it's going to be. As I come up, as soon as that pushes my finger out, spits it out, that's the end of the flexion. So here's his flexion, just about 90 degrees. A little bit of rotation, but if I didn't even do that, I would say, oh yeah, it's pretty good. I can probably get to there. I want to truly see what the hip is limited, because we want to say to ourselves, does this person have a capsular pattern, which for the hip is going to be internal rotation, flexion, abduction, different orders. But the first thing, one of the things that go away is hip flexion and internal rotation. So as we go up, if he's limited, knowing his limitations is very helpful. Help us predict, hey, it's going to be more of a capsular type restriction. So it's a really nice way. So thumb is just below ASIS, right above where the joint will be for the femur. As you come up, as you go up, it'll start to push your finger out of the way. That's how you know you hit the end range of that hip flexion. And then you can take a measurement from there. And then again, use that as your sign. Keep testing and testing as you treat the patient. Are you seeing progression? You'll be able to use your goniometer and see what kind of range you're getting. Rob Shapiro from Technique.